Okay, well, welcome to our fourth Embedded Economist seminar series. Today we've got Dr. Bogda, or Professor Bogda Koczwara, who's an oncologist I've known for many years, and Jonathan Karnon are going to speak again. At the end of last 2 weeks ago session, Rob Padbury said he found it a bit strange talking to a small audience here, but we had 404 people online at the time, so I think that's just some evidence of how successful this is. And I was just talking with Jonathan about how we would get some feedback from people about how the series has gone. So maybe next week or at any time that you'd like, give us some feedback. We've got Slido today. We could have feedback through Slido, or you've got Jonathan, you've got mine, you've got all the presenters. We're all on the Global Health, so you can contact us through that or through the university. We'd love to hear what you think of this. Anyway, I'm going to hand over to Jonathan to start us off again. Thanks, Jonathan.
Pleasure to be here for the fourth time, and as Andrew said, presenting with Bogda this week and focusing on the design of interventions. Bogda's going to talk about the design processes that she goes through when designing interventions, and I'm going to talk about how we might incorporate economic modelling to support that design process. So just to start by acknowledging the traditional owners of the lands on which we're presenting and which all attendees are sitting, and pay our respects to the leaders past, present and emerging. As Andrew said, we've got Slido open, so please make use of that if you're able to. You can see the event code is #L052 this week. Just quick recognition of the funders, as usual. So the Health Translation SA, MRFF funded an Embedded Economist project, and the NHMRC Partnership Centre for Health Systems Sustainability. So the outline, the two-stage outline for today's talk, Bogda's going to talk about defining the problem and designing the solution using her iScreen study as an example. And then I'm going to talk about how an economic modelling framework could inform that design process using hospital-acquired hypoglycemia as a case study. So with that, I'll hand over to Bogda. Sorry.
Thank you very much, Jonathan. It's great to be here, and it's really exciting to be able to speak to you with so many of the audience being online. I think that this is an example of designing intervention that actually addresses the current problem. So what I'm going to talk about is how one designs interventions that address challenges in oncology that relates to health services interventions. Now, I'm a medical oncologist. Until very recently, my core business had been providing systemic treatment for cancer, so using drugs to treat cancer. And the types of design of intervention that I'm used to is identifying how a particular drug could treat cancer. And the design here is relatively simple. You need a person and a drug that targets the tumor, and you need the tumor to assess the response. So this is really a very sort of simple approach, although probably getting a little bit more complicated. When you have an intervention that addresses other aspects of cancer care, let's say getting cancer patients to exercise, or making sure that the flow of patients' diagnosis, treatment, etc. is efficient and responds to needs, the process is a little bit more complicated, and I hope to give you some examples. So what I'm going to do today is cover three sections. Firstly, we'll talk about how do you identify the problem. Secondly, how do you design the solution? And how do you put it all together and make sure that the problem and the solution are somehow connected? And I'll give you the example of some of the work that we're doing at the moment. So let's start with defining the problem. I'm a fan of looking at the problem from the perspective of what is the gap that you're trying to address, that is the gap between what currently happens versus what you want to see happen. And also, in thinking about the gap, what perspective you take in assessing the gap, and that relates to the importance of context. So let's start with the gap. In research, the gap could be in knowledge, in practice, in policy, or all of the above. It's worth thinking, where is it that you can create the biggest impact? And that may be identifying a population that's most at risk, or potentially identify the population that most benefits. And in fact, they may not necessarily be the same population. It's worth thinking which gap you're trying to address. It's very hard to address all three unless you have infinite amount of time and money. So, and even with that, you need to start somewhere. So which gap would you want to address? Can you measure the gap? And that's important because hopefully you would measure the outcome and see whether your gap is shrinking or not. And can you, similarly to drug development, understand mechanisms and targets? Because ultimately, if you understand why there is a gap, you would know what to target. And of course, you need to be sure that you can reach the target in designing your intervention. So there are some similarities between drug research and health services research, but really the key issue here is the complexity. So when you think about the interaction between the tumor and the treatment, or the patient and an oncologist, it can be thought of in terms of two factors. Now, when you think about health service interventions, there is much more complexity to it. So in the ideal world where you have the interaction between an informed, active patient and a prepared, proactive healthcare team, there are a lot of factors that influence both. They might be policies, social expectations, cultural expectations, literacy of the patient that will impact on how patient engages with the healthcare system. And with regards to the healthcare team, there is a certain workflow, the system design, there is an evidence that drives your practice, certain guidelines. There might be IT supports that provide decision support and decision making. All those factors will impact on how the interaction takes place, and you could target all those factors. And there will be different perspectives coming from different aspects of that interaction. I've been reminded of the difference of perspective when I was asked to give a talk in Brisbane, and I was asked to comment on what it is that cancer survivors may want or need. And it made me think that there's a bit of a difference on what it is that you want and what it is that you need. And the difference also relates to who it is that you ask and how. So let me give you an example. Traditionally, if you look at the literature about what cancer survivors need, what are their unmet needs, you would see papers like these. This is a paper from a colleague in Melbourne who summarized the most common unmet needs of cancer survivors. And you would notice in a table below, in the second column, that the most common needs are psychosocial and supportive care. Now, that is not surprising when you think about how these questionnaires that were used to derive the data were designed. And the way they are designed is you undertake a series of focus groups, ask patients and cancer survivors what they think as important issues to them. Then you summarize the factors, you translate them into a questionnaire, and then you go to another group of patients and ask questions that kind of tease out these issues, which means that what patients identified in the initial design of the questionnaires will be what will be included. If they didn't think about something, or if you didn't ask a question to tease out a particular factor, you may not get it. Now, I'm acutely aware that when I ask patients of what's important to them, they would often say, I want to live for as long and as well as I can. So another way of asking the question is to ask this question: what do cancer survivors die of? And this is the result of the study, also from Australia, that tried to shed some light on this particular issue. This is the study from Tasmania that analyzed data from the cancer registry and analyzed nearly 9,000 deaths of people with cancer in Tasmania, and had shown that the major competing cause of death is, in red for both men and women with cancer, cardiovascular disease. So if we want to get cancer survivors to live a long life, we need to treat and hopefully cure their cancer, but also manage their cardiovascular disease. That was not an issue as a priority for cancer survivors, perhaps because that was not something that they were aware of. This information has only just come out into the know. So when you're thinking about what are the issues that people identify as important, it's worth considering who you're asking and through what perspective you're asking, and also consider what it is that you know and what it is that you do not know. And cardiovascular disease, until recently, had sat in this space that I call the unknown unknown. But that is changing. So this gives you some idea about the complexity of defining the problem, but perhaps also some steps in trying to tease out what the problem is and measuring it. Now let's move to the solution. I've already alluded to the fact that the solution depends on whose perspective you're looking at, and that will guide you to identifying your stakeholders, people who have a view and vested interest in an issue that you are discussing. And ideally, you want to have them at the table to co-create and co-design the solution. The difference between co-creation and co-design is that co-design is really designing the intervention, and co-creation is implementing or testing the intervention as well as the design. So co-creation is bigger than co-design. So you would identify stakeholders that are relevant because they have a vested interest in what it is that you're doing. You can also look at stakeholders from a slightly different angle, and that is the workflow that takes place. And this is a very busy diagram, and it's deliberately busy, again, to show you the complexity of what it is that you're looking at. This is borrowed from a paper just published in the Journal of National Cancer Institute that looks at healthcare teams. And this example relates to the management of lung cancer, but you could apply very similar diagrams to other cancers or other healthcare processes. And you would see a big rectangle on top that relates to the context within which the healthcare is delivered. So policies, the payment structures, the community expectations, patients' characteristics, etc., etc. And some inputs. The teams that you're working with that focus, in this case, on management of lung cancer, will have certain composition, certain expectations of how they deliver the care, certain boundary expectations, for example, boundaries between acute service versus primary care service, certain cultural arrangements, power distribution, etc., etc. And they can operate within the facilities, like teams within Flinders Medical Center, or they can operate between the facilities, between different hospitals, between different states, etc., etc. And you would draw on a particular team or teams for particular tasks, which are the clinical processes of care, which go from detection of cancer, diagnosis, staging, treatment planning, survivorship care, surveillance, etc. And you hope that this complex process delivers certain outcomes. So when you're thinking about a problem that you're trying to solve, you would think about which aspect of that complex dynamic and workflow you may want to influence, and that will determine who will be the stakeholders that you would wish to engage with. And that really would mean that your stakeholders are not just people who are recipients of the interventions, but those who are involved in the intervention, from the very top down of CEOs who determine the strategic plan for the organization, to those people who check in the patient into the clinic at the administrative level, and everybody in between. I often refer to this paper, an oldie but a goodie, 2007 paper from British Medical Journal, that summarizes some practical steps in designing and evaluating complex interventions in healthcare, not just cancer, but in general. And the building blocks and the outlines taken directly from the paper are summarized here. And they kind of recap on what I've touched on already. You consider the context, you start by defining what is the problem you're trying to fix, and then you go into optimizing the intervention and optimizing the evaluation, and they are related because effectively your evaluation needs to reflect on what it is that is the core active ingredient of the intervention. And once you've optimized that process, then you can proceed to a more robust randomized control trial. Now, on paper, the approach is kind of stepwise and very linear. So you start with a theoretical consideration, what is the gap, what is the intervention, you think about some modeling of how this could work, what is the target. Then you design exploratory of a pilot trial, optimize the intervention, optimize the measures, and then you could move to the definitive randomized control trial. In practice, often that step from 0 to 2 is one combined activity where you do all of these and you kind of move around them to refine, adjust, tweak again, and to get you to the point where you actually refine your intervention and your evaluation appropriately. When you're designing the intervention, I find that this diagram is actually a useful starting point because it divides the building blocks into sort of manageable chunks. So this is what's called the double diamond design process that takes you from what's at the bottom, discover, define, develop, and deliver stage. And you would notice that each diamond consists of the broad analytical phase and then narrow synthesis phase that leads to a particular prototype, and then more feedback, more analysis, and then more synthesis. So in practical terms, you would start the analysis by asking a question of what is the biggest problem, what is the biggest priority for the users, what are the barriers to addressing the problem, what are the opportunities, and then through that you might say, well, the best return on investment or the best target would be such and such. Those could be the potential solutions. That gives you the prototype that you could take to your stakeholders again, have another discussion. Does this capture what we've discussed? Do we need any tweaking? Refine, try again, and then go into the pilot. As you would notice, the whole key here is changing behavior at the system level, not changing behavior for an individual, but for the entire complex system that works together. And in changing behavior, there are certain theoretical models that might guide you how to do it. This is a diagram taken from the Canadian Patient Safety Institute recommendations, and I often think about it by starting from the top hexagon in blue and sort of goes in circle, and what you're trying to achieve is the bit in the middle, the knowledge translation and quality improvement of whatever sort. And the first step is really to consider whether the organization is ready for change. I recall that a few years ago we were trying to develop a model of delivery of survivorship care in South Australia, and we engaged with a number of organizations around the state, including the Royal Adelaide Hospital that was just about to move to the new location. And I can tell you that in theory we had great interest, in practice we had no uptake whatsoever. They were just not ready to deal with that as they were moving lock, stock and barrel across the road. So organizational readiness for change is a very important factor. Then it's worth considering barriers, facilitators as well as opportunities. For example, we have better funding for lymphedema now, which gives us an opportunity to develop lymphedema services. Much better opportunity now than what we had a few years ago. Then once you consider barriers and facilitators, you might start thinking about what implementation strategies you might have, whether they would be identifying champions that will stimulate others to change practice, or having a reimbursement option, or some other incentive forms, or any other strategies that kind of align with the barriers and facilitators, and then placing it in the context of the health service that you work with. And then trying to see whether you could embed it into the normal clinical practice and workflows. Once you've done it for at least 6 months, you can start thinking about how can you settle for sustainability. But that's really the last project once you've had a chance to do this type of work for a little while. So how do we put it all together? Let me give you an example. So this is the study that we're conducting at the moment called the iScreen study, which is the study to develop and evaluate a web-based portal to screen for patients' reported outcomes in cancer. And here I would acknowledge my study team and the funders of the project. What's iScreen study? It's a pilot implementation study of PRO screening, or patient-reported outcome screening, in every patient at Flinders Medical Center using a web-based portal. Patient-reported outcomes report on patients' subjective perception of health, functional status, unmet needs, and quality of life. They can be collected from patients either online, by smartphone, or using paper and pencil. The whole key is that you can ask the patients what matters to them, as opposed to assuming that you know what does. What we're trying to do in this study is testing whether this process can be done. We are not testing for the evidence of efficacy of PRO collection. We want to know whether it is easy for staff and patients to use PROs, and does it impact on what patients and staff would do after, and does it add to the workload? So what is our gap? Our gap is not in knowledge, our gap is in practice. The evidence for efficacy of PRO collection is quite robust in cancer in particular. This is the paper from JAMA published by Ethan Bash and colleagues, where patients with metastatic cancers of the variety of types were either randomized to web-based reporting of symptoms or usual care. And that reporting of symptoms was sent to the nurse coordinators at the Memorial Sloan Kettering in the United States. And then the various outcomes, including quality of life, were analyzed. What was really compelling here was that patients who reported their symptoms or unmet needs had a longer survival, and the median survival gain was 5.2 months. Just to give you some comparison, this is what was taken by presented by Monika Krzyżanowska, who discussed the study, which was, by the way, a plenary presentation at the major oncology meeting in the United States. This is the current study, 5.2 months median difference in overall survival, and how it compares to some of the new modern targeted therapies in cancer. And with the exception of the soft tissue sarcoma treatment, the benefits from just identifying what patients need outweigh the other targeted treatments. And it was effectively simpler and cheaper than the other treatments. Now, of course, this is not just asking patients what they need, it's actually asking and doing something about it. Now, you would say, well, this is just one clinical trial from New York, so be it. Now, this is the data taken from Canada, from Ontario Cancer Centre, presented a year later at the same annual scientific meeting. And this is administrative data from cancer patients who are exposed or unexposed to ESAS, which is the tool used for collecting this information. In Ontario, screening for unmet needs has been used since 2007, and this graph shows you that people who use the tool to report on their unmet needs live longer than those who don't. So the evidence for use is already there. But what is missing in our study is the practice. There is a practice gap. We do not routinely collect PROs, and when we went to the nurses and informally talked about nurses and doctors, informally talked to them about what it is that would make them use it, the issues arose were identifying the tool, identifying what you're going to do once you know what the needs are, and having a simple system of doing it that does not encroach on your workload. Here's the tool. This is the ESAS, or Edmonton Symptom Assessment System, which is used in Canada. It's a one-pager. You could do it with a piece of paper and pencil that asks patients about common symptoms to rank them, and if the patient's symptoms are higher than 4, there you have a traffic light system that sort of alerts the healthcare provider that there is a problem. There is also a set of boxes at the bottom that allows patients to add to it. So it's not that you have 10 symptoms that you could ask about. You could also ask about physical needs, social needs, spiritual needs. So quite a gamut of needs that one can identify. Most importantly, this is borrowed from the Ontario system. There is an easy algorithm for what you do if the patient identifies a symptom. And in how we're designing our study, we can provide information to the patients the moment they are assessed of what they could do, but also information to the nurses who would initiate the assessment of what they can do with the patient. And again, you would see the traffic light system that tells you how to intervene, in this case for dyspnea, but the similar workflows are available for all the other symptoms. We also have a portal, an online portal that could be used. We've adapted it from the ADAPT portal, which is a portal used for screening for anxiety and depression. And we basically said we're going to screen for anxiety and depression and pain and nausea and insomnia and whatever else, and create a traffic light system that alerts the patient and the healthcare provider that there is a problem and what they can do to address the problem. So back to the co-design process. Our co-design was sort of fairly fluid, but involved a range of interactions. We engaged with the hospital leadership very early on at the variety of levels, including the hospital management, the cancer services management, the different divisions. So we wanted to initiate our interventions using cancer care coordinators, and they are based in medicine and surgery and obstetrics and gynecology. So we reached to the nurse coordinators for all the 3 divisions, trying to explain what it is that we want to do. We've engaged with the nurses. We asked, and there are 14 cancer coordinators at Flinders across different settings, different contexts. And we said, would it be meaningful to you? And the response that we received was actually quite positive. This is what they do. This is the most important part of their work, sorting patients' problems. So they were quite, and they still are quite enthusiastic about this approach. We had some preliminary discussions of what would we need to put on the portal. The nurses don't want to spend a lot of time entering data for the patients. It has to be simple. The process needs to be easy to move from the computer to paper. We have paper case notes. Can we print and put things in the case notes? How quickly do we initiate a response? How do we ensure that the patient who needs help is alerted that somebody may not be giving them a response on Sunday afternoon? Can we do it safely? Can we have disclaimers? So we've engaged with consumers. We've spoken to consumer advisory at Flinders, and we've also spoken to patients who across different services. And we're still in the process of refining the portal, and we're very much at the second stage of co-design and refinement, and we expect that that process will be ongoing. So our process is to go through that first phase of co-design, adaptation, and portal development, then move into the phase 2, where we'll be testing the use of the portal in 50 patients, pragmatic number, just to see whether this is feasible. And our evaluation will include feasibility, acceptability, cost, and safety of this approach. So to sum up, the key questions from my perspective that relate to the design of the intervention are: what is the gap that you're trying to address? Whose perspectives are relevant to addressing it? What can you target? Can you reach the target in your intervention? And the last one, what can you measure and how in assessing the response? And I hope that I've given you some insights on the first 3, not so much on the last one, because I think I'm going to leave it to John, but I'll leave it here with my contact details. I'm very happy to answer any questions. Thank you.
Thanks, Bogda. I just before John starts, and I'm sure John might want to make a couple of comments. It was a great talk. Thank you. I don't have expertise in the area, but if I can quote you, I think you said early on, if you ask a cancer survivor what's important to them, they want to live as long and as well as they can. And I know from the data that you presented, and then I think there was a meta-analysis in JAMA a couple of years ago that I asked John about last time we were here, that sort of suggested that health-related quality of life did not correlate with length of life in these patients. And in fact, often we're talking about this drug might improve your life expectancy by 3 months, but your health-related quality of life may not improve there. So how do we disarticulate those two? Or is it important? Or if you asked cancer patients to pull those two apart, what's the most important bit?
I'm not aware of good studies that will rank outcomes, saying, that will tell us what's most important. And I suspect one of the reasons for it is because the answer is it depends. It depends on a particular individual, on their individual circumstances, the expectations of their cancer. We know, for example, that people who have families are more likely to value survival at a cost of compromise to quality of life than people who do not. That does not necessarily mean that survival is objectively more important than not, but I think that's a very compelling argument for asking patients. The other issue is that the studies that show prolongation of overall survival in cancer tend to correlate with improvement in quality of life. The dilemmas about how good quality of life as a benefit is relate very often to studies that show progression-free survival without gain in overall survival. And very often in that setting, quality of life is either not measured or doesn't change very much.
Thank you. Have we got no questions on Slido at this stage? We might come back, stay around.
Yes,
John, thank
sure.
you.
Oh, I was just going to ask you a bit of a leading question, Bogda, relating to the economics, really. So in your experience, to what extent, I mean, you talked about measuring costs in your pilot study, but to what extent do you think cost effectiveness and value is incorporated within that design process?
I think there are two things to be said here. I really think that if we want to get from the change in practice to the change in policy, we must have health economic analysis. It's really critical. We don't do that very, very well. Many studies that argue for change in practice and policy do not have any health economic data, and I think that that's a tremendous omission. So I would argue for that. It's a bit tricky building in health economic analysis into studies like these because they require quite a lot of data input. For our current study, at the moment, we're grappling with the issue of how do we measure cost? Do we get the nurses to actually record what they do for a period of time, which is labor intensive but more accurate? Do we ask them for a subjective estimate of how long it takes for them to do what they need to do so we can have a comparator? So even for a small study like this, we're already struggling with, we do not want to overburden the nurses, but we want to have a reasonably accurate estimate. And the final thing is we need to be very clear of what it is that we're measuring, i.e., do we measure what is the incremental cost here? And for this particular study, I would argue that asking patients how they are is our core business. And if we ask patients how they are and we'll discover that they have unmet needs, we will do something about it, and that might actually increase our healthcare utilization, and that is not a bad outcome. In fact, that's the outcome that we want to see. So we need to be very careful what we measure. We do not want to measure the health economic data and say, well, we've identified lots of needs and patients saw lots of providers and that added to the cost if it improved their outcomes. What I want to know is how much extra time does the nurse need to spend to collect information using this tool as opposed to what he or she would have done routinely.
I suppose I'd just add to that you measure the cost, you increase the cost, but if you also measure the benefits, then at least you can make an assessment as to whether the additional benefits justify the additional costs.
Exactly.
So, yeah.
Thank you.
Okay. Thanks, Bogda.